Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. Today is Top 10 Tuesday. It's the 149th Codecast podcast episode, and we are at the last Tuesday of the month, and so I give you my top 10 coding, billing, and compliance questions, and we have pretty much a packed show today. So just taking a look at anything from ICD-10 to CPT and a couple of compliance questions thrown in. I apologize if you can hear my fan in the background. It's very hot here today, even though we have air conditioning on in the office. It just gets really, really warm. So number one, and I'm going to start right into it. During an arthroscopic rotator cuff repair, the surgeon made an additional incision or portal site to repair the subscapularis tendon. How should this be reported? Okay, so when we're talking about rotator cuff, we're talking about the shoulder. And you'll have to not only look at CPT when you talk about inclusive services or unbundled services or services that could possibly be excluded, you have to look at even CPT assistant. So the additional incision, according to AOS guidelines, and that's the American Academy of Orthopedic Surgery, or portal site, is not separately reported and is considered an inclusive component of the CPT code 29827, which is arthroscopy shoulder surgical with rotator cuff repair. So this code represents the repair of 1, 2, or 3 tendons, and the number of portals made does not alter the use of this particular code. When another portal is required to repair the subscapularis tendon, then it's still considered to be inclusive of the component of that major procedure. So you have to really read not only your AAOS guidelines, but also if you can find a CPT assistant on it, that's also can be really helpful to you when you're reporting this or trying to have a conversation with your physician. So sticking with orthopedic, number 2 is how do I report a superior labrum from anterior to posterior? So that's called a SLAP, lesion and capsule repair. So 2 codes can typically be reported together, and that is the 29806 and 29807, but only if the SLAP lesion repair is type 2 or type 4, and that's specific to the AAOS Global Service Data Guidelines. So it has to be listed that way within the op report. And that is you must have 2 separate problems. So one must be a capsular defect, not caused by the SLAP, and then a SLAP tear. So again, that superior labrum anterior posterior tear. Documentation needs to support the type of SLAP lesion being repaired. Again, type 2 or type 4. Number 3, and this is actually my last one on orthopedic. This is from a Chicago client, and she asks, what is the correct usage of CPT code 23420? And that says reconstruction of complete rotator cuff avulsion, chronic, including acromioplasty. Okay, so yeah, this is a little bit different than just a repair. And what the 23420 is intended to identify is an old tear. So remember, when you see chronic, this can mean that it's been there a while or is an ongoing problem that's persistently getting worse. Also, there was something that recently that I read, well, not too recently, within the last few years that I read with AAOS guidelines, is they think that chronically, if you don't have it specifically listed as chronic, but it's been there a while, if the patient is over 35 for orthopedic, they're considered that's an old patient. So 35, boy, it's getting younger every year. But also the quote coming out of a CPT assistant, because I had to go back and see if there was any kind of direction from the AMA on this, not just AAOS. And it says this type of extreme tear usually requires rearrangement of the normal anatomy and sometimes grafting with other biological or non-biological material for repair. So this was CPT Assistant, October 2005, Volume 15, Issue 10 on pages 23 and 24. And when I found also the information on the AAOS site, it said if there is a significant retraction with a large tear, extensive releases and mobilization may be required as well, justifying the use of the 23420. So if fascia, autologous connective tissue taken from the patient, or synthetic material is required, that code is also appropriate. If a tendon transfer was performed, you can also get 23397 with a 59 modifier in addition to the 23420 code. So it's helpful when they give you more information than you actually asked for. One of my new Coding Corner membership clients asked today, and I appreciate them, they're from Los Angeles. So Terry, I need to pre-cert a procedure and I cannot find the codes anywhere since you know we don't do cardiovascular medicine and they're a billing service. So it says, how do I code a selective subclavian left and a left vertebral angiography that the doctor said and a stent in the left vertebral? Okay, so you can have the angiography codes and you'll be able to code them, and it's an inclusive code of 36226. Okay, so that includes the catheter placement, the introduction, and selectively engaging not only the left subclavian, but the left vertebral and injecting dye. That's what angiography is. And then examining the patient from that dye perspective. When it comes to knowing, can you code more than one code or not, the subclavian vessel and also the vertebral vessel, they are in what we call the same territory in the cerebral area, in the head area. So you're not going to be able to code each one separately. If you were in a carotid, for example, then you could code the carotids as well. But on the same side, we call that the ipsilateral side, so the same side of the patient's body. If you are performing a selective subclavian and a selective vertebral on the same side, and here that's it, then you're only going to be able to capture one service. It's a hierarchy of codes. Now, when it talks about, and you asked about your vertebral stent, now this gets a bit more challenging because, and this is why you probably couldn't find it, this is what we call a T code, which is in the back of your CPT book under the new technology code section, and transcatheter placement of intracranial vertebral artery stent is 0075T. The problem is this is considered investigational by most payers and not FDA approved yet. By Medicare, I don't think they're going to pay you. So check with the facility on how they're approaching this. I can't even find a clinical trial for reimbursement. So you'd have to get direct from payer approval, not only to perform it, but also to get paid on it. And also your facility, is it going to take a free service or let you perform it? So making sure you're asking them how they're handling it will be important for you. Number 5, it's one of my clients in Orlando, Florida. So Terry, we submitted a few claims for COVID-19 testing and we were denied. We used the new ICD-10 code that became effective April 1st, U70.0, and we were not sure why a denial. Well, right away I can tell you where the denial was. So U07.0, that's the new code for vaping related disorder. U07.1 is the new code for the COVID-19 acute respiratory disease. So you missed the digit. You actually coded for vaping versus coronavirus. So make sure you go back and send corrected claims on all of those, because that would be as of April 1st. So again, U07.0 is what you used. That's vaping disorder instead of the COVID-19. And the new COVID-19 code for a test that has been confirmed to be positive is U07.1. So you just have to go back and correct your claims. This Codecast podcast is also brought to you today by Charles Schwab. Be a more informed investor. Follow us for news and insights to help you own your own tomorrow. AboutSchwab.com. Okay, on to number 6. This is from a New Jersey client. I have a physician who insists he can bill a level 4 visit code for a telephone audio-only call with the patient as long as it lasts 20 minutes. Please help because all we do is argue. Okay. Under the telehealth rules under waiver 1135, it is specific, and it has been specific in every single update they've given us, that you can only bill an office visit code 99201 to 99205 and 99211 to 99215 if you have audio and video two-way interactive capability. If you don't have that, you have to defer to the phone call codes 99441 to 99443. That's all you can do. There is not any exceptions on that for Medicare. So I would direct your physician to that waiver. Number 7, and this is from one of my New York City clients. Okay, so this one is interesting, and I had to actually do some research, and I've had this happen a couple times, and so I want to be sensitive as I'm responding to this topic, because this is just a little different, okay? And it's also something that you may run into as things evolve in healthcare. So it says, Terry, we have our first ever patient identifying his or her gender as X on their driver's license. The patient wants a prostate screening, but the payer, Athena Healthcare, is denying and won't even authorize the service because that is for a male patient in their system, and it's running up against an edit, and we have what we call a non-binary patient. Also, this patient is a transgender and has transitioned to female, but again uses the X for their gender sex identifier. Okay, so I know this is complicated, so let me just give you kind of the rundown of how to handle this. In 2017, there was a Senate bill signed into law that also included a claim level condition code 45, and that is for ambiguous gender category, to identify such claims that pose a gender procedure conflict. So I've used it with commercial payers as well, and it has pushed the claim through, but it does have its challenges. This is becoming more and more prevalent and will continue to be an issue when non-binary and trans patients seek care because, and you should be aware of this, you know that the president and the administration and CMS was rolling back some of the hefty regulations that are out there to get anywhere with what you do. Well, one of the regulatory informational things that the president rolled back and HHS rolled back as of 8/18, and it passed, they implemented some revisions to the Non-Discriminatory Act for reporting purposes that may not recognize the non-binary patient only as the sex of the patient, male or female, when it comes to certain things in treatment. So there's still some legalities there that I'm sure will be challenged, but unfortunately you're a little bit stuck here. So you have to at least try the claim level condition code 45, try to put that in there as an ambiguous gender category to identify that claim, and then try to push that through. What we've also talked to the patients about, and we've had a very sensitive conversation with them about that, is it sounds like the patient went from male to female. And so we sit down with them and say, I understand how sensitive this is, and we want you to feel comfortable, but I may need to use your biological gender or what it was, your sex type. And sometimes they don't feel the same, that population of patients doesn't feel that word means the same thing. But again, have a sensitive conversation and just say your biological sex type could get this paid. And when I try to use your driver's license designation, it's not getting paid. So you may have to pay out of pocket for this. So the biggest thing is sensitivity. You still want to offer the service because you do not want to get into any legalities of not only denying care, but not giving access to care to any population of patient that needs it. But you also have to let the patient know that there's some realizations that they have to consider if they want to get things covered under their insurance. So they can have anything that they want. Again, different patient populations. I'm not just talking about transgender. But if you want it, you can have it if you're willing to pay for it. But if you want it considered under insurance, then you may have to look at a conservative approach. And that's the only thing I can really relate it to. So some challenges there for sure. Number 8 from a New York client says, Terry, my practice is moving to a different location, to Virginia, and the staff is in the process of purging old patient records off of the mainframe computer. Is there a best or legal way to dispose of records where the patient is no longer living or no longer part of our practice? Okay, so there's a website under the Health and Human Services Office for Civil Rights website in the OCR, and anyone who is charged with disposing protected health information, the PHI, must be trained, including any volunteers you use. So there are a few different options as the privacy and security rules do not specify a particular way to dispose of them, but covered entities cannot dispose of PHI in dumpsters or other places where the public or other unauthorized persons could get to it or have access to it. So in general examples of proper disposal methods, these could be included but not limited to, for paper records, shredding, burning, pulping, pulverizing the records so that the PHI is rendered essentially unreadable, indecipherable, and otherwise cannot be reconstructed. For PHI electronic media, and you're clearing out something, so using software or hardware products to overwrite media with non-sensitive data, purging, they call it degaussing, or exposing the media to a strong magnetic field, in order to disrupt the recorded magnetic domains or to storing media, disintegration, pulverization, melting, incinerating, or shredding. So you get my drift here. It has to basically be something that can't be reconstructed by anybody for any kind of use. So go to the hhs.gov for full details on how to do this and just plug it into their search method. Number 9, and this is from an Arizona client. Hope you guys are okay out there. I saw 114 degrees the other day. Terry, we are a practice that kind of did what you discouraged us against doing, and it has to do with the CARES Act money. Okay, I remember this question. So, an HHS deposits. You said there was a lot of money being pushed out, and you gave us a recommendation in your Medicare updated webinar saying use CARES Act money, feel free, make sure you have good accounting, use HHS deposits that came in April because those are considered grants and won't have to be paid back. Be careful on your PPP loans because they may be waived or forgiven if you can reflect that it's directly related to COVID-19 and the pandemic. But I was very clear. It said, our practice decided to apply for, and we were approved for the very thing you told us and recommended strongly not to do, the Medicare Advanced and Accelerated Payments. And we just realized after receiving $120,000 way back in April that they're now being recouped as of August 1st. Medicare takes 50 to 70% of our checks, of our Medicare checks, and they're offsetting our amounts. And we got a letter saying they will continue to do so until the loan we received is paid off. Also, they're taking a 10.25% interest rate. Is there any way to stop or delay this? And okay, here's my answer. I hate to say I told you so, but no. The Federation of Hospitals is trying to do that as well to no avail. They're saying this should be waived. But CMS was clear. They said we have 4 different things that you can have that are considered grants, that are considered, we'll waive it. But if you're saying that you're going to apply and agree to accelerated payments, that means you're taking a loan against what you could get. And they were clear. 120 days, we're taking it back. Medicare sent out $60 billion in Part A providers, $40.4 billion, almost 24,000 providers under Part B. And this was given out between April and May. You have 120 days to use it, and then they're asking for it back. You're stuck. There's no way to get around that. So now you know why I said I would not have done that. Number 10 question. What is the code for an upgrade from a single system pacemaker to a dual lead system? So there's one code for upgrade. It's different if it was going to a biventricular pacemaker, but if we're just going from single lead system to dual lead system, you would code 33224. This includes using one of the existing leads or electrodes, either the right atrial or right ventricular lead, and then adding a second electrode because now you're upgrading to a second, and then changing out your battery or your pulse generator because now you have to have an additional connector. So again, 33224. Okay, so my personal tidbit this week, it's hot, and I mentioned at the beginning, and I like to call it FOT, and you know what I mean when I say that, and I don't use profanity, so I'm trying to be clean here, but I live in Southern California, and I hate humidity, and it has been over 100 degrees for 5 days straight. I'm having trouble sleeping, and I just looked, and we're at 67% humidity, and I know those of you that are in Florida, you're laughing at me right now, or New York, but I'm grumpy, so I need to go get my Starbucks extra iced tea, because I am having a really tough time with this heat. Even with air conditioning on, you still just feel gross. But hopefully this dome of heat is going to stop soon because it is miserable. Okay, so everyone, on this Terry Tuesday, thank you for spending some time with me. Just a reminder, if you get a chance, please rate us on iTunes, Apple Podcasts, TuneIn, Google Play, YouTube, wherever you listen to this on your platform. But those ratings really help keep us on air and also generates really, really well when it comes to sponsors. So we appreciate that. But make it a great day and a great week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.